Okay, I think we'll go ahead and get going. I'm here till 6 o'clock tonight anyway, so it doesn't matter to me. So we'll just keep talking until you go home. So we talked, first we did Glargine, and we went through Prozinc in cats. We're going to talk a little bit about Vetselin in cats. Now, this study was done using the Lenti product, the Vetselin, the porcine-derived. This was back in 2008. So this was with the Intervet Sharing Plow product, which is, again, the same product that is out there now. So what they did is they took 46 cats with diabetes and followed these cats out for either during initial stabilization and then continued, and some of the cats, for half of the cats, to follow them for longer periods of time. And they started them at a dose of 1/4 to 1/2 unit per kilogram twice a day with a maximal starting dose of 2 units. Now that was just how they did the study. I'm not sure that that is a real thing, that you have to limit it to 2 units, but that's what they did. What they found was that 28 of the cats were classified as going into, not remission of diabetes, but control of the clinical signs during the study. And in 23 of the 28 cats, that occurred during the initial stabilization, which was the first 16 weeks. 7 cats went into remission either during that period or later on. And so a total percentage of cats going into remission was 17%. Again, very similar to what Jackie saw when she did her study comparing Glargine to Lenti and the PZI. So only 17% of the cats went into remission. Clinical signs of hypoglycemia were associated in cats with doses of more than 3 units or more than 1/2 unit per kilogram per injection twice daily. And that was observed in 9 of the 46 cats. So in this study, using the Lenti product at these dosages, they saw more biochemical hypoglycemia and more clinical hypoglycemic events than were recorded either in the Glargine study or in the PZI study. And biochemical hypoglycemia was recorded in 6% of the blood glucose curves and was typically associated with dosages of 0.75 or higher twice daily. So I think there's a couple of things about this study. Yes, it works to control hyperglycemia in cats. It is a reasonable insulin to use in cats. It's not probably the insulin of choice if we're looking at newly diagnosed cats because only 17% go into remission. Same thing, low percentage of cats on PZI going into remission. But it certainly would be an insulin to use if you have cats who aren't going into remission with Glargine, aren't having good control, and you want to try something else. It would be a reasonable option for that. And it looks like as you get above 3/4 of a unit per kilogram twice a day, you're probably approaching a point where the cat is either going to have a hypoglycemic reaction or, by definition, the cat's going to become insulin resistant. And so in the next hour, we're going to talk about insulin resistance in diabetes in both dogs and cats, and we'll see that it is highly dependent. Your definition is highly dependent on the type of insulin you're using, whether it's a basal or a non-basal insulin. The other insulin that's been looked at that people are interested in cats, so this was just reported last year, is looking at Levemir or Detamir insulin. Again, this is another basal type insulin like Glargine that we talked about earlier. And what they did with the Levemir in these cats is they took 18 cats diagnosed with diabetes that were either newly diagnosed or had been previously treated. So these were some cats who had been on some other insulin preparation for a while. What they found was an overall remission rate of 67%, which the reason it probably is lower than the Glargine studies because they had cats that were being treated with other insulin products first. And what Jackie's found, and I think has been our clinical experience, is that if you're seeing a cat now who's been a diabetic for more than 6 months, has not yet received a basal insulin, and you want to put it on either Detamir or Glargine to try and get remission, you're not going to see it. So if you have a cat who's been a diabetic for more than 6 months on another insulin product, the chances of remission drop substantially. So the time to get a cat to go into remission with Glargine or Detamir is on day 1. Those are the cats that you really want to get. Probably what happens is that if they've been on another insulin product for more than 6 months, that's resulted in further beta cell loss, and now they're going to become permanently diabetic because there is no recovery that's available anymore. We can't reverse the glucose toxicity. Now what she saw, again looking at that 6-month number, was that the remission rate was 81% in cats that saw Detamir prior to 6 months, but only 42% in the cats that did not. No significant differences were identified between her outcomes for Glargine or Detamir, and this wasn't head up. It wasn't a study that compared Detamir and Glargine together. It was taking her previous Glargine data and comparing it to the Detamir data. And the thing that we're going to see is much different in cats than it is in dogs is that the dose of Detamir in cats is the same as the Glargine dose. The dose of Detamir in a dog is crazy low. So when we talk about dogs, we're going to talk about using 1/5 of the amount of insulin that we would normally be giving if we were using an NT or an NPH or a Lenti class insulin. So this is probably also a reasonable insulin to use as initial management of a diabetic cat. Probably going to be similar to Glargine. We just don't have as much experience with Detamir in cats. The other thing we should mention about Glargine, or just some management things about it, is that it says on the bottle it's good for 28 days. And that's true, that its licensed indication is that once the vial is punctured, it says it's only good for 28 days. That's primarily because the manufacturer of the insulin didn't look at it, stability for longer than that, because people are going to go through a bottle. They don't really need it to hang around for a longer period of time. Jackie's looked at the stability of Glargine and has found that as long as the owner keeps the bottle refrigerated, it's good for 6 months. So as long as it's refrigerated, it's probably good for 6 months after the bottle's open. They don't have to throw it away, which greatly reduces the cost, because one of the things that owners freak about the Glargine, using Glargine, is they think it's too expensive. So we try and tell them, look, it's going to be good for 6 months. And more importantly, hopefully your cat's not going to be diabetic that long. And the whole goal is to make your cat not diabetic, which is greatly going to lower the amount of money that you're going to have to spend on your cat. All right, so let's talk about dogs. So again, these are the same 5 insulins that we looked at in cats. These are all insulins that we have data on for dogs. I guess what I should back up and say, for cats, my initial insulin of choice for a newly diagnosed cat would be Glargine. If that's not working, if we're not getting remission, then it probably doesn't matter what other insulin you want to use. I think PZI would be fine. NPH does not appear to work very well in cats. I wouldn't use an NPH in cats. But in cats, either using Glargine or Detamir initially, and if you don't get remission by 6 months in those cats and you want to switch to something else, I'd probably switch them either to Lenti or PZI. In dogs, now that Vetselin's returned, this would be the initial insulin I would recommend in all diabetic dogs, primarily because it has the postprandial hyperglycemic lowering effect. But all of these other insulins we'll talk about in terms of the data that exists for them. Now, this is one of the bizarre things of veterinary medicine. We've been using NPH insulin in the dog for 40 years. This was the first paper that showed that it worked, 2009. So well done. You guys have been doing a crackerjack job of using that product. A recent paper last year came out looking at the PZI recombinant human insulin. So this is the Prozinc product, using it to treat diabetic dogs. So it is approved for use for dogs and cats. Most of the interest initially in the data that we showed before was all heavily skewed towards cats. So what we see in dogs, and again I'll just show you some graphical depictions of glycemic control. This was a 60-day trial in dogs. These are going to be box plots of their average blood glucose concentrations over time. So the average blood sugars at enrollment, we're going to be looking at this line, which is the median line, is going to be about 450, 470. And then looking at the average blood sugars over time out through day 60, you're going to see that their average blood sugars were still around 300, which is still above renal threshold. So most of these dogs had average blood sugars that exceeded renal threshold. However, you're going to see that control of their clinical signs was present in a higher percentage of dogs than that. Looking at their fructosamine concentrations, average fructosamines were quite high, in the high 500s. At day 60, they were lower. They were down into the mid 400s. Again, that's significantly higher than normal. But again, we were seeing control of clinical signs in dogs using that product. But what you're looking at is that while the starting dose was a half a unit per kilogram, most of the dogs that got out to day 60 needed 1 unit per kilogram twice a day to control their clinical signs. So it looks like the dose of PZI in looking at dogs is higher than the dose that we would normally be looking at with using a product like Lenti insulin, which we'll talk about in a minute, or with looking at NPH. So let's talk a little about Vetselin. Again, it is back on the market now as a Merck product. It had a tortured manufacturing issue that was sorted out by the folks at Merck and by the folks at the FDA. A couple of things to remember about it is it is porcine derived. Again, we talked briefly about that, the effect of no anti-insulin antibodies being present because pig and dog insulin are identical. It is a U40 insulin, which means that we have to make sure that owners are always getting U40 insulin syringes. No good comes of measuring U40 insulin in a U100 syringe. Nothing good ever comes of this. And I've seen websites which are just absolutely insane, which show an owner how to take a U100 syringe and do the math and make the gradations. That's just crazy. People can't do anything. And you're going to tell me that they can do that? No, that's just not humanly possible. So you just have to make sure that they get a U40 syringe when they're using this product. And usually where things get screwed up is, and this is another bizarre thing about owners, is that you give them 100 syringes and they look in the box and there's 3 left. They don't seem to be concerned about that until there's none left. And that always happens Friday night at midnight. And so what they'll do then is they'll go into the pharmacy, Costco, Walmart, wherever, and they'll say, hey, my animal's a diabetic, I need syringes, and they'll just give them a box of U100 because they're going, what the hell, who uses U40 insulin? And the owner doesn't read it because it says in microscopic letters on there it's a U100 syringe. So just make sure they're using the right syringes. Definitely, it's been looked at, does it result in anti-insulin antibodies? Looking at dogs that were given human, porcine, or beef-derived products, they do make antibodies. A small percentage make antibodies against human or beef, but none of them make antibodies against the porcine product. Now, what are the kinetics of Vetselin in dogs? And again, it's a mixture. There's an amorphous insulin fraction and there's a crystalline insulin fraction that's present in the same vial. So what you see in the dog is that the amorphous fraction reaches maximal effect 4 hours following injection, and that lasts for about 8 hours. And then the effect is maintained by the crystalline fraction, which has its peak effects around 11 hours. And the duration of activity, now this doesn't mean the duration of glycemic control, it means the duration of activity, is anywhere from 14 to 24 hours. So in the dog, it's BID. And in fact, with every insulin product that we've talked about, once-a-day dosing just doesn't work. The only time that we ever look at once-a-day dosing are cats that are going into remission or weaning them off Glargine, so we're going to go from BID to SID to off. But SID insulin just doesn't seem to work. And in cats, the peak activity with the amorphous fraction is sooner. It may occur at 1.5 hours, but it can also be longer. That's just the beauty of the cat. It does average about 4 hours, with duration of activity also being shorter in the cat, between 8 and 12 hours. This is the real advantage, I think, of using the Lenti product, of using Vetselin in dogs, is that, again, this amorphous insulin peak helps blunt postprandial hyperglycemic reactions. So like I said, if you have an animal on NPH and you're noticing that the first few hours after meal and after insulin, the blood sugars are going up, that's a good dog to switch to Lenti insulin because you'll block that postprandial spike. And it's that postprandial spike that contributes to exceeding renal threshold and glycosuria and also results in progression of cataract. So you would like to be able to keep that from happening. Now, one of the things that has changed, partly due to the manufacturing issues that were present before and looking at the stability of this compound, is that this is an insulin that needs to be shaken, not stirred. This needs to be shaken. Now, we were always taught, oh, dear God, carry it around in a velvet vial, which always amazed me because people run around when their pancreas is moving all over the place and insulin doesn't seem to explode. But we were always taught, don't shake the insulin, roll it, massage it, treat it nicely. No, shake the shit out of this stuff. Because the problem is it's got to go into suspension because you'll see it's a thick, milky stuff. And so you want to shake it. The owner needs to shake it. And it needs to be shaken thoroughly until you get, as described, a homogeneous, uniformly milky suspension. Now, if you shake it really hard, what you're going to see, it's going to get foam at the top. We don't want the foam. Foam is bad. So we need to, after we shake it, we need to wait for that foamy stuff to kind of dissipate, invert the bottle, put the syringe in there, and extract the wonderful things that are in there. But you got to shake it. And we found this disturbing. I was on a panel that met with Merck, and they told us that we were going to have to shake the stuff, and there were like 7 of us in the room going, dear God, are you kidding me? Because we've taught people for 59 years, don't shake it. And people are going to look at it and go, yeah, I probably don't need to. You need to shake it. You know, you're just going to have to shake it and lose the fear. The other thing to look at is if you see clumping or particle precipitating out, that's probably not good. So if you've shaken it and you're not seeing that stuff all go into solution, probably you need to get rid of that bottle and get another one. And right now the product has a shelf life of 12 months and a labeled stability of 42 days once you pop the vial, once you open the vial. Now I'm sure at some point someone will do some studies on looking at, can you get away with more than 42 days? That's what we do as veterinarians. We push things to the limit. If at some point we have data showing that it's good for longer than that, we'll certainly pass that out. But right now, once you poke the vial, you're probably going to have to replace it after 42 days. And again, this would be the insulin that I would use for starting virgin diabetic dogs. Now, what about Glargine? Last year, again, a nice paper on Glargine in dogs. You know, the basal insulin with the magical mystical properties that we talked about for cats. Dogs don't go into remission. Okay, the vast majority of dogs, unless they're diabetic because they have Cushing's or because they're on a steroid or because they're in diestrus, generally are not going to remit. So we're not really looking to push them in terms of glycemic control to be normal and trying to get them to go into remission. So mainly we're looking at control of clinical signs. So what they did is they took 12 dogs with newly diagnosed diabetes, gave them Glargine twice a day for 6 months. And then they did rechecks 1, 2, 4, 8, 12, 24 weeks, and at 6 months. Looked at clinical signs, BG curves, primarily generated at home, and looked at serum fructosamine. What they found was that average blood sugar started to drop by 2 weeks and remained significantly lower throughout. Polyuria and polydipsia had improved in 91% by week 24. That's a long time, actually. You know, that week 24 is 6 months. So you have to be a little bit careful because I don't know what your average pet owner is going to deal with, but 6 months to stop peeing in the house, that probably is not going to work very well. But by the way they did the study, by 6 months, 91% were better. They did not see clinical signs as a result of hypoglycemia. Again, this seems to be an issue of basal insulins. One of the advantages of basal insulins, you don't get these big rises in serum insulin post-administration, so it seems to markedly decrease the likelihood of a hypoglycemic attack. So what they determined was that Glargine administered twice a day is a possible, interestingly worded, and safe method of treatment for dogs. But when they looked at the control of the glucose, the remission of clinical signs, it looks like the success rates with Glargine are going to be lower than NPH or Lenti in terms of owner assessment and veterinary assessment and control of things like PUPD and body weight. So I don't know that it's a go-to first choice insulin in dogs. I think if you're not getting good control with Lenti, with Vetsulin, and you want to try something that might last a little bit longer, it would be certainly something to look at to try Glargine. What I would probably do is if we're going to use a longer acting insulin in dogs is go to Levemir, which is the Detamir product. So this has been looked at as well as in dogs. Glargine is a basal insulin because it's at a low pH. Levemir is a long-acting insulin because what they've done is they've taken the insulin molecule and they acetylated it by adding a fatty acid chain to the tail of the insulin molecule. And what that does is that acetylation step allows it to bind in a reversible fashion to albumin. And so what it does is that once it's absorbed from the sub-Q site, which is also delayed by the acetylation, once it gets to the sub-Q site and gets into the plasma, it binds to albumin, where it slowly dissociates and is released to become free insulin. And then it goes ahead and does its effect. So we get a prolonged effect from the sub-Q absorption and a prolonged effect from its release from albumin. if we look at what we know about clinical studies that have been done in dogs, it's not a whole lot. There's not a lot of published data on its use in dogs. What they did is that there were some studies looking at taking normal dogs and 5 diabetic dogs and basically doing what's called a euglycemic clamp. So what you do is you take a normal dog or a diabetic dog, you continually monitor their blood sugars and titrate the amount of insulin to get to a given blood glucose concentration. And in order to keep their blood glucose constant, you adjust the amount of glucose you're giving them. So basically what it is, it's a measurement of the efficacy of the insulin in controlling a high blood sugar. And what they found was that you could get really nice glycemic control using insulin detamir in diabetic dogs, but this stuff is way more potent on a unit per unit basis than any of the other insulins that we use in the dog or the cat. And in fact, the dose for a dog is actually going to be 1/5 of the dose that we normally recommend. So what we've been using Levemir for is that if you have dogs that are not doing well on Lenti or NPH, and it looks like the duration of action is short, like they start to become hyperglycemic by 5 or 6 hours when looking at their blood glucose curve, I would probably go ahead and switch them to detamir, but what I would do is start them at 1/10 of a unit per kilogram twice a day. And again, based on the data that we've seen with other basal insulins, you're probably not going to see as much in the way of adverse hypoglycemic reactions. You probably are going to see biochemical hypoglycemia in these dogs. But I think it is probably the insulin I would go to if I wasn't getting control with NPH or the Lenti insulin products. And again, you're just going to have to go really, really low. And that means that for some really, really small dogs, it's going to be a tough sell. Because at 1/10 of a unit in a 2 kilogram dog, it's going to be really difficult for them to try and use that product, and they cannot dilute it. So you can't use diluted Glargine or diluted detamir because you're diluting out the stuff that makes it Glargine or detamir. Okay, so when we're getting ready to send the owners home, and we've decided on the insulin that we're going to use, whether it's a dog or cat, and we've talked to them about diet, we're going to talk to them about what to do, what to monitor in terms of clinical signs, what to do in terms of insulin techniques, how to give it, injection techniques. In general, what we recommend is alternating sites, left, right, front, back. Anywhere where you can feel a rib is probably a good spot to give insulin. We don't want to keep giving it in the same spot because there's some data showing that repeated injection in the same site causes dermal atrophy and subacute fibrosis, which may affect absorption, so you just want to keep rotating it around. We tell them how to store and handle the insulin, how to draw it up into the syringes, what to look for in terms of a hypoglycemic reaction. So if an owner thinks that their dog or cat is having a clinical hypoglycemic reaction, what is it that we usually tell them to do? Give them Karo syrup, give them sugar, feed them. And that's what we continue to tell them. And then unfortunately somebody did a study where they gave Karo syrup to diabetic dogs that had insulin-induced hypoglycemia, and they quickly figured out it does virtually nothing. And so now what I tell people is give it Karo syrup as you're driving your dog to the emergency clinic, because chances are the Karo syrup's not going to work. The problem is that Karo syrup, those simple sugars, are absorbed very rapidly across mucous membranes, and what happens is their blood sugar goes up. But as soon as the blood sugar goes up, the insulin that made them hypoglycemic says, oh, the blood sugar's going up, I'm going to drive all that sugar right back into the cell. It's a very transient effect. What does work to control hypoglycemia is glucagon. So glucagon injectors, which human diabetics usually carry, very potent way of reversing insulin-induced hypoglycemia, very safe to use. The downside is that they have to give it as an injection. They have to give it intramuscularly, and they have to keep rebuying these glucagon injectors to make sure that it's not expired because the shelf life is pretty short. But they could go ahead and give a milligram of glucagon or a 0.5 milligram of glucagon, which will rapidly reverse the hypoglycemic reaction in their dog or cat. Urine monitoring, we don't recommend it unless you don't like the owner. In which case, then it becomes like insanely mandatory that they monitor their urines, especially diabetic cats of owners you don't like. They should all do that. The other thing that you should do is identify the practice in your area that you don't like, which you probably have already done. But what we do is we have, where our hospital is, we have our hospital, and then we had a rental car agency, and then we had another vet hospital, and we didn't like that hospital very much. And so what we decided was whenever we had psychopathic diabetic owners, and these are easily recognizable. These are people who come in with Excel spreadsheets. These are people that come in with, books from the internet, stuff that you've written that they're asking you, have you seen this before? And you go, yeah, dumbass, I've actually seen that before. They come in saying they're Dr. So-and-so, and you find out that they have a PhD in linguistics, and you use one word with more syllable, and they're looking at you weird. Or they're nurses. All of those people are immediately disqualified. So what we do is that, if we're having an interaction and it's clearly not going well, I say, excuse me, I'm going to go to my office for a minute, where I'll go and do something. And then I'll usually come out with a book, and the book is Ettinger's internal medicine book, because that happens to be the practice that was located next door. And I would say, you know what, this dude, he's right there. And so we're going to copy your records, get your x-rays ready, trundle you on down there because he's the man. And then Ettinger figured out there's something not right here. I don't know why these crazy people are coming into my practice. And so he looked at it and goes, well, they don't have a book, so, what the hell. So what he did is he said, that VCA hospital, that's free clinic. They're completely funded. So you would see people on Sepulveda Boulevard, psychotic people, with their dogs walking back and forth. So you need to find that practice that you don't like. It will improve your quality of life. All right, let's talk about food first. We're going to talk about dogs, and we'll talk about cats. For people, the American Diabetes Association recommends that diabetic humans eat a diet that's high in carbohydrate, low in fat, high in fiber, which seems inherently weird. But what they're telling you is that actually they want you to eat a diet that's high in complex carbohydrates. Complex carbohydrates have to be broken down by enzymes in the intestine before they become simple sugars and then are absorbed across the gut. They want you to have low fat because of stroke and heart attack, and they want you to have high fiber because it helps with glycemic control in terms of gastric emptying. Now, this is also the recommendation for diabetic dogs, and we have lots of data showing that the use of these types of diets in the dog lowers average blood glucose, lowers fructosamine, lowers average insulin dose, decreases the amount of glycosuria. Good stuff. Lots of studies both in clinical and research diabetic dogs. The problem comes in with the reality of the world. What is the *1 brand of dog food in the United States? Purina. That's so funny. That's funny. You're funny people. Purina's like highbrow crap, man. That's state-of-the-art food for what?
Dog chow.
Old Roy. Oh, yes. Walmart. #1 provider of dog food in the universe. I don't know what's in Old Roy. I don't want to know what's in Old Roy. What I do know about Old Roy, it's $7 a ton. So you go to the diabetic dog owner and you say, look, these are the foods that we like. This is the rationale for using these foods. It's slightly more than $7 a ton, however. Therefore, you need to tell me now what you're going to do. Because what you don't want them to do is say, yeah, I'm going to feed WD, and then go home and feed Old Roy. Or go home and feed Old Roy, followed by whatever was cheapest at the store, followed by whatever is cheapest at the store. So what you need them to do is to commit and say, look, these are the best diets. At least in a dog, we're really not worried about or hoping for remission. So what we're hoping for is stability. So at least tell me what you're willing to feed so that we can tell you how much to feed, when to feed, so that now the only variable I have to worry about is the dose of insulin. I don't have to worry about what creative stuff that you're doing on your own. So, if they'll feed Old Roy and they're going to just feed Old Roy, then that's phenomenal. The other thing about Old Roy that's mystical is they eat a pound of Old Roy and they defecate 45 pounds. And they don't ever seem to lose weight. So I don't understand any of that stuff. So these are all foods. I don't know. I don't have a strong view other than probably high complex carbs, high fiber are probably the way to go with these diets. Now, what does high fiber do? And the American Diabetes Association argues back and forth, as do gastroenterologists, how much fiber we should eat in the United States. Apparently we don't eat enough fiber. The main thing with fiber with respect to diabetes is that the main effect that it has is it delays gastric emptying. And by slowing gastric emptying, that slows the delivery of calories to the intestine and helps coordinate the absorption of those calories with the onset of action of the insulin that you've just given. So by delaying gastric emptying, it helps, again, blunt the evil, which is postprandial hyperglycemia. Now, high fiber also has some magical properties in terms of post-receptor and pre-receptor effects of insulin interacting with the insulin receptor, but most of it has to probably do with delayed gastric emptying. Now, you should be very proud being Americans. Are there any Canadians in here? Yeah, excellent. You're not number one, you're number 2 in the world. We're number 1 in the world in defecation. We poop more per person than any other country on the face of the planet. And people study this stuff. I don't understand. Scandinavian people apparently defecate once every 4 months. And this used to trouble me, and then I realized from a simple evolutionary standpoint, if you evolved in a country where it was dark 10 months out of the year and super cold, you would say, I'm not going out there. So you would eat food that would be designed to allow you not to have to defecate so much. And this has a point to it, by the way. I think it does. Yes, it does. The role of food in treating a diabetic, and they're talking about using all these fiber sources. When we go to diabetic rounds at the Human Hospital at UCLA, what will happen is these people will come in with their calendar of what they've been eating to show to the nutritionist. And they'll come in with their blood glucose curves that they've been generating at home. And the way it typically works is that they usually sit down in the doctor's office and invent it while they're waiting for the exam. They go, holy crap, I ate fruit and vegetables, blah, 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 and I did my glucoses 49 times a day for the last 3 weeks. And then they go in and the endocrinologist says, your A1C's up, your weight's a disaster, your eyes are worse, what the hell, you're lying to me. And then the nutritionist comes in and screams at him. Then the nutritionist gets up, rolls down the hallway to some machine and eats like 45 Twinkies. So, you can't rely on these people. So I've decided the Brouette's Rules of Nutrition. This applies to you. This has nothing to do with veterinary medicine. So write this down. Because you will not see it on a slide because I don't want to be responsible. Rule number 1, you're going to die. I've decided this. Are there vegans here? You're going to die. You're going to be miserable, but you will die. Rule number 1, you're going to die. Rule number 2, eat towards your death. So decide how you want to go. Stroke, heart attack, colon cancer, red meat and fat, baby. Way to get you there. You don't like red meat and fat? You don't want colon cancer? You're a fish eater? Yeah, not so big on fish, but fish is nice. Eat fish, stomach cancer. Phenomenal. I don't know. Colon, stomach, not either one. I don't want either one. So eat towards your death. Be happy about it and just accept it. And then you don't have to get caught up in all this other stuff. It's just not worth it. It's just too stressful. So now, do these high fiber diets work? Well, I said that, we had lots of data in dogs that these diets work. And then what happened in 2009, 2 papers came out in the same month, different journals. One paper said these high fiber diets have no effect on diabetes. And the other paper said, this is the greatest thing since sliced bread. And so what happened in this paper is they took a bunch of diabetic dogs who were thought to be well-regulated in terms of control of PUPD, body weight, and cataracts. And they switched them from whatever food they were eating to a high-fiber, moderately carbohydrate-enriched food. And what they found was that over the course of the next 4 months, they were no better. That's odd. So they were good to start, and they didn't get better. Therefore, they said it didn't have an advantage, which seems inherently bizarre to me. In the other study, what they did is they took a bunch of diabetic obese dogs and placed them on these types of diets, high fiber, high complex carbohydrates. And what they found was that there was improvement in glycemic control, reduction in body weight, and more importantly, what they looked at were these inflammatory cytokines being produced. And now, as you probably know, obesity is really, fat cell is not just a thing that holds fat. A fat cell apparently is a cell that's insanely metabolically active, produces a variety of hormones, some of which are inflammatory, and really obesity is being viewed as a disease of inflammation, and a lot of the sequelae of obesity are related to inflammation. So what they looked at in this study was that not only did they lose weight, and have improved glycemic control if these inflammatory mediators went down eating these foods. So there you go. So what I've chosen to do is ignore the previous study and just deleted that from my database and just continue to believe that these diets work. Long-term monitoring then of diabetic dogs and cats. I mean, there's a variety of things we can do. We can do assessment, our assessment of symptoms, owner assessment of symptoms, monitoring of body weight, glucose curves, and glycemic parameters like fructosamine. And there's been several studies that looked at, of all of those things, clinical signs, either by you or the owner, BG curves and fructosamine, what is the most accurate predictor of actual glycemic control? Clinical signs. Clinical signs, especially in dogs. If you're controlling clinical signs, that means renal thresholds not being exceeded, which means your blood glucose curve is probably going to be pretty reasonable, which means your fructosamine is probably going to be pretty reasonable. So in dogs, I think what it means is that we can rely less on just doing random blood glucose curves. I think you do a blood glucose curve in a dog when you're starting insulin to figure out what's going to happen, and at any time you're getting poor glycemic control to find out why that's happening. But you probably just don't need to bring the dog in every 3 months for a glucose curve if he's doing well. You might want to bring him in to see what's going on with his body weight, to check him for urinary tract infections, to look at cataracts, but I don't think you need to bring him in for curves. And there's several papers in dogs showing that if you bring him in for a curve on Tuesday, and then you wait a week and you bring him in for a curve the next Tuesday, and you show the curves independently to somebody, they're likely going to make different recommendations. And I think that has to do with the fact that that's just life. You know, everything changes day to day, and so what you're looking at, and the reason that clinical signs is the best parameter, is because that's an overall view of what's happening. Yeah.
When you start them, how do you initially figure out what their dose should be?
For dogs?
Yeah.
For dogs, I just start, depending on what insulin we're using, if we start at we just start at a half unit per kilogram BID and tell them to go away for a week. And we're going to do the first assessment of glycemic control 7 days later.
And what is your assessment consist of?
For a dog, we're going to curve them. We're going to have them preferably curve them at home. We'll talk about that in a second. Preferably curve them at home, but we're going to curve a dog. And with cats, like we talked about, we're not going to curve cats. We're just going to do 2 blood sugars in a cat. Now, let's talk about doing the glucose curves and doing them at home. Can owners do them? Yes. One, we know that owners can do them because we make them do them. 2, we know that there are several papers showing that owners can successfully do this at home. The question is there an advantage to a pet owner or to a pet to have at-home monitoring done? And the answer seems to be overwhelmingly, if you're a cat, absolutely, because we're going to drive you to normal. That's the whole point. And in a dog, the answer is probably. Because it looks like if you look at the data from dogs that are having at-home monitoring, their glycemic control and their fructosamines are better. It doesn't decrease the amount of visits to a veterinary hospital, interestingly enough. 2 papers showed that people who were doing at-home monitoring were more likely to come into the vet than people who weren't doing at-home monitoring. I think it's just because they're motivated. You know, these are people who, if they're going to do a glucose curve at home, they're probably going to take reasonably good care of their pets. So I think there's a lot of value in doing these. It results not only in improved symptoms, it improves in cats anyway with remission, but they can accurately do it. And a lot of people, if they're testing their own blood sugars at home, they can do this. So we use the alpha track meter because, you know, basically there's nothing magic about it other than it's a glucometer that has a chip in it that has a mathematical formula that adjusts the measured blood glucose for whether it's a dog or a cat. And there are big differences between dog, cat, and people in the way we carry glucose in our plasma. How much of it's free in the plasma and how much of it's associated with red blood cells. If you use a human glucometer, a handheld meter on a dog or a cat, what do you usually find is going on with the blood sugars relative to measuring them on an in-house chemistry analyzer? They're lower. Okay? And that's because that human meter is assuming that's human blood, and it's assuming the distribution of glucose is equal to that of a person. So what the alpha track meter does is it takes the formula for dog and cat, it measures the same glucose number, gets the same number, but then it adjusts it with that formula and spits out what the actual glucose measurement is. So we like to measure the blood glucoses initially, both in dogs and cats. Anytime an animal is ill or is showing progression of clinical signs, it's really nice. The owner says, you know, the dog's not looking well or he's more PUPD today, say, you know what, the first thing we should do is, why don't you go measure your dog's sugar? Because if the glucoses are persistently high, that's a whole level of different differentials versus if the glucoses are low, that's a whole level of different differentials. So anytime they're sick or showing progression, it's nice to curve them. Anytime we change the insulin dose, it's nice to be able to have the owner assess glycemic control. And anytime we're doing that aggressive insulin protocol in a cat, we want them to be able to measure it at home. Now, what we've been doing for dogs is we sell them the glucometer and all the parts. For cats, because we're hoping that the cat's going to go into remission, we basically rent them the meter and they buy the reagents. Because the goal is that hopefully your cat goes in remission. If they don't want to have a glucometer at home and pay the money for it when they don't need it, that's fine. They have to bring it back. And then when they bring it back, we use it in the hospital for our hospitalized patients. We don't try and resell it. And the way that we're doing curves in dogs is that we'll do it pre-prandial, pre-insulin. If it's a dog or a cat that's on NPH, Prozinc, or Vetselin, we're going to do it every 2 hours or until nadir, until their glucose gets to the lowest. Or in a cat on Glargine, we're going to do pre-prandial, pre-insulin in 4 hours post and no other glucoses. And again, we're going to do it for 12 or until we hit the nadir. And then we're going to use, in dogs, it's in the notes, but there's a similar dosing adjustment scheme for dogs like there is for cats. Long-term glycemic control, we like to look at fructosamine. You can look at A1C. That's what they look at in humans, the amount of glucose on red cells. The problem with A1C in dogs or cats is that the lifespan of the red blood cell is much different in dogs, cats, and people. The reference range is much different. The reference range is much tighter, which means it's harder to look at trends, changes in glycemic control. So we really like to look at fructosamine, which is really just a glycation product of albumin. It reflects glycemic control over the past 2 to 3 weeks. Now, some important things to remember about fructosamine is that it takes 2 to 3 weeks to affect the change, so there's no reason to measure it more frequently. The other thing is that you don't want to use fructosamine as your sole criteria by how to adjust insulin dose. So rising fructosamine doesn't mean more insulin. Rising fructosamine means worse glycemic control. And now we have to figure out why there's worse glycemic control, which means we need to do a physical, do blood, do urine, and possibly do a glucose curve. But we have sometimes people who will equate a rising fructosamine to say, well, I should raise the insulin dose, especially in cats, because we all deal with nasty cats where no one can get blood from them. My own cat is this way. I have a hyperthyroid cat. He's the world's nicest cat until you restrain him, and then he becomes some psychomanic thing. And so to do anything to him, we have to blow dart him and get blood from him. If you have cats that are like that, who are diabetic, and you're trying to sort out, what's going on with glycemic control, and they're that nasty, I'm not opposed to using fructosamines to try and figure it out. Chances are poor glycemic control in a cat's going to be associated with too little insulin. But what you could do is take a mean cat with rising fructosamine and just keep raising the insulin dose until the symptoms go away and his fructosamine normalizes, because one of two things are going to happen. Either you made the right choice and the cat's going to get better, or you made the wrong choice, the cat's going to have a grand mal seizure and die, in which case you made the right choice. So either way, it's a win-win for you. The owner may not view it as such, but they're just going to have to deal with it. A1C we already talked about. Okay, let's talk about why cats are frustrating. Cats don't become diabetic because of anti-insulin antibodies and chronic pancreatitis. The vast majority of cats become diabetic because of amyloidosis. And so what happens is that there's an age-related increase in the amount of amyloid being deposited in their beta cells over time. And what we see is that diabetic cats have more islets affected and a higher percentage of amyloidosis than non-diabetic age-matched cats. So this is a pancreatic biopsy from a normal cat. This is the exocrine pancreas. This is the islet. Lots of nucleated cells within the islet, and this is a stain for insulin. This is a pancreatic biopsy from a diabetic cat. If you look in here, what you see are far fewer nucleated cells, and then I don't know if you can see, but there's this amorphous stuff that's in the islet. That's amyloid. And in the beginning, when people first found this association between amyloidosis of the islet and diabetes in cats, the question was, is the amyloid there because there was some insult to the pancreas, there was inflammation and the amyloid came in as a secondary response, or is the amyloid the primary event in cat diabetes? And now I think most of the data shows it's the primary event. And what happens is that this islet amyloid that we see in cats is actually the product of a normal peptide being secreted by the islet, which is islet amyloid polypeptide, or IAPP. So all mammals, dogs, cats, and people, every time we secrete insulin, we secrete IAPP. What happens is that in dogs metabolize that IAPP and excrete it. 80% of adult humans metabolize IAPP and excrete it, but 20% of adult humans don't. And so IAPP accumulates in the area of the islet and is one of the reasons why people develop non-insulin dependent diabetes. And 100% of cats do not metabolize IAPP. They lack the enzyme pathway. And so what happens in cats is that as they get older, more IAPP accumulates in the area of the islet, undergoes an enzymatic reaction to get converted from IAPP to amyloid. And once it's converted to amyloid, that's it. You can't get it out of the cell. You can't reverse any of the changes that occur in the islet. And we know that islet-associated amyloid and IAPP play a role because amyloid over time will cause physical injury to the mitochondria of the islet, kill the cell, and then the cat will actually go from a state of non-insulin dependent diabetes to a state of insulin dependent diabetes. We also know that if you have too much, IAPP serves a role. It's supposed to do something. And what IAPP does is that when it's secreted from the islet, it turns right around and binds to the islet and says, okay, you just secreted insulin, you can turn yourself off. It's a counter-regulatory hormone. What happens over time is that if you have relatively more IAPP surrounding your islet, then it's telling the islet don't produce insulin, even though the islet is capable of producing insulin, it needs to produce it. So as a cat gets older and becomes obese and lays down more amyloid and IAPP, it develops something called glucose toxicity. And glucose toxicity occurs in the cat when the average blood sugar gets above 300. So in the domestic shorthair, when the average blood sugar gets above 300, the islet cell membrane now becomes impermeable to glucose. Glucose can't diffuse into the islet. If the islet doesn't know what the peripheral blood glucose concentration is, its response is to not make any insulin. It turns itself off. Then the average blood sugar continues to climb. The cat goes from being glucose intolerant and hyperglycemic after a meal to being hyperglycemic between meals to being PUPD, polyphagic, and losing weight. Cat comes into the clinic. You diagnose it as being diabetic. You put it on a high-protein, low-carbohydrate diet. You put it on a basal-acting insulin. The average blood sugar in that cat drops below 300. When it drops below 300, the islet cell membrane becomes permeable to glucose again. Glucose comes in. The islet is fully capable of making insulin, starts to produce insulin again, and what you notice is that the blood sugars start to drop, your exogenous insulin requirement starts to drop, and the cat goes into remission. This is why cats go into remission, is because they have a reversible form of diabetes, at least in the beginning. And they have this effect of glucose toxicity. So this is the reason why cats respond well to diet. You're reversing glucose intolerance by switching them to these types of foods. And this is why cats have a high remission rate, if we can keep them in remission, by lowering the amount of carbohydrate. Because as they eat more carb, they secrete more insulin, which means they secrete more IAPP, and as a result of that run into issues. Now, one of the things that people are looking at is to get away from insulin treatment in diabetic dogs, diabetic cats, and diabetic people. And if you look at the survival of diabetics from the time of the discovery of insulin until now, what you see is that from the 1940s on, there's no difference in longevity. Insulin by itself doesn't restore and doesn't reverse the effects of the diabetes. It doesn't control your glucose effectively enough. And part of the issue is the route of administration. When we give insulin sub-Q, what doesn't happen is that there is no first pass effect. So normally when insulin's released, it goes from your pancreas into your portal vein into your liver. It's degraded, then it gets into the peripheral circulation, and then it does its thing. What happens now is that we give insulin via an injection, goes to subcutaneous tissue, is absorbed, goes systemically, eventually gets to the portal vein, eventually gets to the liver. So a lot of the issues with poor glycemic control and long-term diabetic complications are certainly related to hyperglycemia, but there's a lot of evidence that it's also related to hyperinsulinemia, and that insulin in high concentrations is actually one of the toxic things. So what people have been looking at are there other ways to help regulate blood glucose short of or in addition to giving insulin? And what I was taught in school was what happened with glucose was very simple. You ate food, the food went from your stomach into your intestine, you absorbed glucose across your intestinal wall, that got into your portal vein, that glucose went to your pancreas saw that the blood glucose was going up because you just ate and you made insulin, you secreted insulin. It ends up, it's frickin' way more complicated than that. And actually what happens is you eat a meal, your stomach distends, puts food into your small intestine, your stomach and your small intestine actually start to secrete these things called incretins. And incretins are low molecular weight peptides that live in the circulation for about 3 to 5 minutes. These incretins, of which the most common one is an incretin called GLP-1 or glucagon-like peptide 1, they travel into your portal vein, they go to your pancreas, they tell your pancreas to produce insulin, and they're telling your pancreas to produce insulin way before your blood sugar ever changes. So you're going to secrete insulin in anticipation of the fact that calories are coming. So these incretins, like I said, what they do is that they stimulate your pancreas to produce insulin. They also go to your liver and block the release of glucagon, and glucagon is evil in diabetics because low portal insulin concentrations cause high glucagon concentrations. Glucagon stimulates gluconeogenesis from the liver, which makes your sugars go higher, and it stimulates the formation of ketone bodies. And so anything that we can do to block glucagon and stimulate insulin release will help lower your blood sugar. Now, what happens in normal animals is that you secrete these incretins, they do all these magical things, they only live in the circulation for about 3 to 5 minutes, because in the plasma you have these things called dipeptidopeptidases, and these are enzymes that eat incretin. Because if the incretin stayed around forever, you'd go hypoglycemic. So they're just supposed to live long enough to get your pancreas to produce insulin, and then they're rapidly cleared from the circulation. So what has happened is that pharmaceutical folks and biochemists have come up with 2 ways of trying to make this pathway work. One is to develop synthetic incretins that you can give as injection or orally, and then develop drugs that block dipeptidopeptidases so your endogenous GLP-1 levels will stay persistently high. And so as a result of that, 2 products have been developed and are on the market now to treat people, some of which we have data for in cats. One is Byetta, which you've probably seen the commercial for. Again, if you were here yesterday, I love pharmaceutical commercials. This is a classic pharmaceutical commercial. The woman's dancing around her kitchen because her diabetes is like exquisitely well controlled. Her limbs aren't falling off. Everything's looking grand. In the background, you hear the beauty of Byetta and all the wonderful things that it does. It stimulates production of insulin, normalizes hypersecretion of glucagon, delays gastric empty, improves satiety. Pretty much anything you would want in a diabetic drug, it does. Byetta is actually an incretin mimetic. It is a derivative of Gila monster saliva. It's just weird stuff, but that's where it comes from the saliva of the Gila monster. It's now recombinant, so we're not milking Gila monster saliva in order to get this to happen. However, in the background of the beautiful Byetta commercial, while you're watching the dancing woman in the kitchen, you will hear, may cause death. That's not good. So the may cause death part comes from a nasty fact, which is these incretin mimetics stimulate the release of GLP-1, which then goes to the pancreas. Now, the majority of GLP-1 receptors are in your islet, which is good. However, some people have expression of GLP-1 in the exocrine portion of their pancreas. I'm not sure why, but it lives there. And so when these people take a high dose or take a dose of an incretin mimetic, stimulates the release of GLP-1, causes increased GLP-1 binding to the receptors, it causes massive release of pancreatic enzymes. And these people can get fulminant, nasty pancreatitis, and hence the death. So it actually is a drug that the FDA has one of the dreaded black box warnings on it. So when you look at the box, it has a black box on it, And that's never good. And it basically says, you have to be very careful. If you're predisposed to pancreatitis, if you have a history of pancreatitis, this is a drug that you may want to avoid. The nice thing about the drug, though, is that it's very good at treating and slowing down the sequelae of diabetes in humans in conjunction with either taking another oral hypoglycemic agent or even taking low doses of insulin. Now, there is some work in cats, healthy cats, not diabetic cats. We've treated a few diabetic cats with Byetta. It comes in two forms. It comes in a form you have to give every day, and then it comes in a weekly repositol injection, which I haven't seen any data on in cats. But what we do see in cats is that after using it subcutaneously, it does result in increased serum concentrations, insulin concentration, what it's supposed to do, a decrease in blood glucose, what it's supposed to do. So it all looks like it has the effects that we want it to do. It also has a positive effect on blocking glucagon secretion in cats, so it does lower glucagon hypersecretion. And the other thing that it does in cell culture, which is unique, is that it has an effect on pancreatic beta cells on causing proliferation. So it actually causes new beta cells to be produced. And the pancreas is a weird organ because there are stem cells within the pancreas that live in the pancreatic ducts, and these stem cells have the ability to either differentiate into exocrine pancreatic tissue or endocrine pancreatic tissue, depending on the stimulus. And one of the stimuluses for differentiating into a beta cell is GLP-1. So this is a drug that one of the things that people are interested in looking at in people is not just for its effects on normalizing glucose and glucagon, but also looking at it to cause further beta cell production. So what we see with Byetta is all of the same good stuff in humans, better control of A1C, low risk of hypoglycemic reactions unless they're also taking insulin. It promotes weight loss, which is nice because obesity contributes to a lot of the insulin resistance. Now, the other drug that was recently approved in people is Januvia, and Januvia is a dipeptidyl 4-peptidase inhibitor. So you take it orally as a tablet. Byetta you have to give as an injection. But Januvia is an oral medication. It blocks DPP-4, so it increases the level of these incretins, especially GLP-1. Does all the same things that you would expect that Byetta would do because it's all promoting the effects of GLP-1, so improves satiety, lowers glucagon, increases insulin secretion. Both Byetta and Januvia aren't going to work in dogs because you're not going to get increased insulin release because there's no beta cell left. So primarily these are medications that we'd be looking at to treat cats. And there is one paper looking at a dipeptidyl peptidase 4 inhibitor in cats, and it did lower glucagon levels as expected. But right now, I haven't seen any data on using these in diabetic cats. Certainly I think that what we're looking at is that these are probably medications that we'll get more information about. There's also products that will soon be coming out that are an oral form of insulin that basically is microencapsulated so that it doesn't get degraded in the stomach. There's an ocular and an inhaled insulin product that will come on the market so that they don't have to give shots. There's still issues with those because it's not going to be the same pharmacokinetics in terms of first pass effect. And there's probably going to be other oral hypoglycemic agents that we can look at in dogs and cats depending on their mechanism of action. But this year at the American Diabetes Association meeting, which was in Boston, there was a guy scheduled to give a 3-hour talk in the morning on the use of oral hypoglycemic agents to treat diabetes. And this is a guy who's the head of the Joslin Research Center at Harvard. He wrote a book called The Pancreas. I mean, generally, if you have the cojones to write a book called The Something, you're probably pretty smart. So I decided to go to that session because I wanted to learn about oral hypoglycemic agents. They're the number one prescription drug in the U.S. Thought, well, we should probably at least know about this stuff. Went into the meeting. There was like 4,000 endocrinologists in there and 3 veterinarians in there. We sat in the back of the room because we didn't want to, cause a scene or anything. The guy gets up, takes 20 minutes to introduce him because he's won every award on the face of the planet. He walks up to the podium and says, the way to treat diabetes in 2013 is to use insulin. And he sits down. Now this is 11 and a half seconds into the 3-hour talk. The three of us are delighted because we had tickets to the Red Sox game, and our whole plan was to go to this, enjoy adult beverages, go to the game, and enjoy more adult beverages. Now our day had become grossly accelerated. That we were going to have adult beverages at 8:05. We had to pace ourselves. We were very confused. How are we going to handle this? It's very stressful. And then the guy gets up and walks to the podium and says, the best way to treat diabetes in 2013 is to use insulin. And he sits down again, and I'm ecstatic. We're packing our stuff. And the crowd is like, now they're just agitated. Because these are people who write 90,000 prescriptions a day for oral hypoglycemic agents, and they're not happy about this. And they're physicians, they're uptight. And now he gets up and he walks back to the podium and goes, I take it you want to hear about oral hypoglycemic agents? And we're going, no, not really. I'll read your notes. And he gets up and he goes, okay, fine. The next 3 hours just talks about how every single study comparing any oral agent on the market to insulin loses. Insulin wins every single time. And I said, well, shit, you told us that in 5 seconds. I didn't have to listen. Now, I live in California where people are inherently weird. So they come in and they say, I don't want to use insulin. It's not natural. And you go, okay, this is going to be one of these people. We're going to have this conversation. I don't do the eye of toad. The eye of toad doctor is next door. I mean, you can use that guy if you want. I don't know anything about that stuff. And they'll say, what about chromium or vanadium? And I say, okay, we can have this conversation. So prior to the advent of oral hypoglycemic agents, there was a whole body of literature on using chromium and vanadium to treat human diabetics. Chromium and vanadium have what are described as insulinomimetic properties, which means we don't know what they do. But they probably have something to do with augmenting the effect of insulin at the level of the insulin receptor. They were used, again, before oral hypoglycemics in treating insulin and non-insulin dependent diabetics. And there's, like I said, a lot of studies looking at these things. Now, since the advent of oral hypoglycemics and the use of newer insulins, really nobody looks at this stuff in humans anymore. So there's at least 3 papers on chromium in cats and 1 in dogs, showing absolutely no effect of chromium supplementation on average insulin dose, fructosamine, average blood sugar, or clinical signs. So I would have to say probably doesn't do much. Most commercial cat foods are loaded with chromium, so probably you're not going to see cats that are chromium deficient that might actually benefit from it. And then there's one study in cats showing that vanadium, in a study that compared vanadium to placebo, that the cats in the vanadium group drank less water than the cats in the placebo group, but there was no difference in glycemic control looking at blood sugars and fructosamine. It was very weird because it was like, well, why are they less PUPD, but their glucoses are still terrible? What it ended up was that the cats in this study got vanadium by the vanadium being added to their drinking water, and it tastes bad. So if you want to stop PUPD, put a noxious chemical into the drinking water. What I tell people is, if they want to put chromium vanadium on the food, I say that's grand, go right ahead. But you should probably give insulin and do the other stuff I'm telling you to do. And the other stuff I don't really know anything about. All right, does anybody have any questions on diabetes? And the next thing we're going to talk about resistance.
Just with the cats and their diet, and you're talking about obesity contributing to amyloid.
Right.
Is that the only thing case, or is diet sugar disease feeding them? When they improve with their diabetes on a low carbohydrate diet, is that something that's affecting amyloid?
Yes. So the question was about the diet and the effects of the amyloid and the effects on obesity. We definitely know that whichever diet you're using, if they're losing weight, they're secreting less insulin. If they're secreting less insulin, they're producing less amyloid. So anything we can do to block the effects of hyperinsulinism by reducing obesity will be effective. The high carbohydrate or the low carbohydrate, high protein diets are better than high fiber diets in the cat in accomplishing that in terms of insulin secretion. But in terms of weight reduction, if they're losing weight, you're decreasing the amyloid load.
What about in prevention?
In prevention, yes. Probably in preventing diabetes, if you switched cats to diets that were higher in protein, lower carb before they became diabetic, could you prevent deposition of amyloid? Probably. But it would probably be primarily through reducing obesity. Because we think that one of the main triggers why there's so much diabetes in cats is because there's so much obesity in cats. Probably because the foods they're on have too much carb. Okay, then you get another 15-minute break.